Good morning, everyone. My name is Rissy, and I take this opportunity to introduce you to this interesting piece of work I was involved in collaboration with my colleague Awe, whereby we assessed the current status of traditional and genomic screening in newborns with a special focus in Africa. Did you know that 5 to 10 years from now, every baby born will have their genome sequenced at birth? Well, I look forward to living in such a world. As Hippocrates once said, it is important to know which individual has a condition than the condition which an individual has. And one such application of this anecdote is a newborn screening, which is also known as the baby's first test. This particular technique has been shown to improve the overall quality of life of neonates since its introduction 2 decades ago. This is through early detection and prevention of inborn congenital disorders. Most of these conditions, which are genetic in nature, if not treated early, may lead to lifelong disabilities and sometimes death. This particular technique is currently being used in routine clinical setups whereby neonates are being diagnosed for conditions likely to manifest in their adult, early childhood, as well as in late adult onset. Therefore, our study aimed to document the currently existing efforts on the use of both traditional and genomic screening methods with a special focus in Africa. When it comes to our methodology, we conducted a comprehensive literature review on fully free text PubMed articles, and the key search terms used included neonatal screening, newborn screening, Africa, traditional, and genomics. The filtration process is based on the criteria on my right, whereby, for instance, if the publication date was set to a maximum of 10 years, and if an article maybe was published in 1986, it would be exempted from the review process. This was followed by a comprehensive critical assessment of the abstract content on the relevance of the study. So what did we find out? In terms of the screening methods, the traditional newborn screening methods have progressed from immunoassays to fluoroenzymatic assays to fluoroenzymatic immunoassays and to the famously known tandem mass spectrometry. This particular technique was a game changer in newborn screening, whereby it enabled the screening process to move from just a singular disorder to multiple metabolic disorders at a go. Which brings me to our current state, whereby we have genomic newborn screening, and some of the methods include whole exome sequencing, whole genome sequencing, gene panel-based sequencing, and targeted sequencing. In the gene panel-based sequencing, which seems to be the most preferred method, we have companies designing a specific set of genes in a chip-based format and using targeting specific conditions. When it comes to targeted sequencing, we could target specific genomic regions of the gene to screen for specific disorders. So what are our overall comparators? When it comes to traditional newborn screening programs, developed countries have functional, operational, and legislatively established NBS programs incorporated in routine healthcare systems. And these are actually operational in states in the US, some countries such as Canada, China, and the UK. However, when it comes to the sub-Saharan Africa, majority are at the infancy stages of establishing traditional NBS programs. However, it is noteworthy to know that Benin, Republic, and Ghana are the only African countries reported in literature to have comprehensive NBS programs. When it comes to prioritization of conditions, congenital hypothyroidism is the most cost-effective screen for condition globally. However, in sub-Saharan Africa, hemoglobinopathies and glucose 6-phosphate deficiency seems to be prioritized. This is the case in India and some parts of Asia. When it comes to the screening capacity, 5 to 10 disorders are screened for at a time in developed countries, and most of these nations have compulsory newborn screening programs for specific disorders in some regions. However, in sub-Saharan Africa, only singular disorders are screened for, and they rely on sharing resources with existing immunization and HIV screening programs. When it comes to sources of funding, NBS programs are part of the national health and regulatory and legislative systems, and are usually funded by the government in developed countries. However, in sub-Saharan Africa, like other under-resourced settings, we have most programs rely on funding from non-governmental organizations and well-wishers. When it comes to genomic newborn screening, the US, UK, and China, through the government, have set aside funding to conduct pilot studies for exploration of genomic NBS. However, in Africa, there are limited efforts whereby countries such as South Africa, Ghana, and Tanzania have attempted to document efforts in GNBS by screening for specific singular disorders. So generally, as we have seen from this table, Africa is currently under-resourced and cannot handle genomic newborn screening. What are some of the arising challenges? For traditional NBS, we have issues such as implementation, sustainability, expertise acquisition, and cost in terms of equipment, reagents, diagnosis, and lifelong treatment. And when it comes to genomic NBS, the issue of true consent, whereby we want to know if the parent gave consent for the genomic data of the infant to be obtained, would they be permitted once they reach legal age to retract the information online if need be? Other issues include data privacy, choice of inclusion for conditions, result interpretation, and reporting and method validation. When it comes to our overall findings from this study, it is noteworthy to know that Africa is still at the initial stages of implementing traditional NBS, largely as a result of limited access to resources for genomic newborn screening. Sickle cell disease is the most screened for disorder in sub-Saharan Africa. This could be attributed to the high prevalence rate of the disorder in these parts of the world. Most developed countries have set aside funding to conduct research on the potential clinical utility of GNBS. However, there exists a great discordance on the selection criteria for the gene disease inclusion in currently existing NGS-based panels. So we have multiple panels from different parts of the world. However, the conditions that are being included vary greatly, and that would be something that we need to come up with a consensus agreement on which conditions to include for genomic screening. Compared to developed nations, few efforts have been made to implement genomic newborn screening in Africa. Our findings therefore reveal the unpreparedness of both resource and under-resourced systems to implement GNBS at scale. When it comes to future prospects, this study sets the foundation for exploration of African genomic newborn screening based on our proposed African-specific GNBS panel. This pursuit will be realized in accordance with setup by leveraging publicly available neonatal sequence datasets. So at the moment, I'm currently involved in a study whereby we're leveraging publicly accessible data in a bid to validate our African-specific GNBS panel, which was developed as a result of this particular survey. Some limitation of the study is that it was based on fully free text articles available on PubMed, and other potentially useful articles may not have been included. And this can be attributed to the limited access to funding for this particular research. So these are my references, and thank you, ladies and gentlemen. Kindly feel free to reach me through my contact details as shown in the screen. I look forward to hearing from you. Have a good day.